I want to start by thanking my joint author and her staff and my staff. It's been quite a journey that we are certainly not near the end point today, but our work together has brought us into contact with some amazing people, including our colleagues. And I want to thank colleagues who have allowed us to take up your time and afforded us meetings in your offices and with your staff as we've gone through this. And I also want to thank our colleagues for the very thoughtful and respectful conversation on the floor this morning. It's a conversation that is a tough one and is ultimately a vote that will go to the core of our personal beliefs, our religious beliefs, our ethical beliefs, and so there's not really a wrong vote on this issue. I respect that colleagues will vote what they think is in the best alignment with their beliefs, their religion, whatever may be their guiding principles. I do want to take a few minutes to address some of the concerns that have been raised to make sure that people are clear on the protections that are contained in the bill as the joint author outlined and have been reinforced by the testimony of some others. The recent testimony of my colleague from Stockton cited an issue raised by another colleague of, well, people are free today to end their life. We don't need a law to allow somebody a compassionate end of life. That's right. So let me illustrate how it affected one constituent from the county of Santa Cruz. A work colleague with a diagnosis of a terminal illness with no hope for life chose to end his life with a pistol at his workplace to be discovered by coworkers who are traumatized by that image now for the rest of their natural lives because he wanted to protect his family from those images of ending his life with a gunshot. So there are methods for somebody diagnosed with a terminal illness to end their life. That's why this bill seeks to establish a compassionate alternative to other horrific options. I also want to address, I think, a notion that needs to be corrected, that a physician's ethical responsibility is to cure, to treat, to protect, to extend life. California today recognizes the right of a patient, of you and me, of our families, to sign an advance directive where we direct our caregiver not to extend our life, not to resuscitate, not to feed. They are intervening in a manner that respects our legal right as a patient not to extend our life, but they have the means to extend our life. What California has recognized is both the primacy of the doctor-patient relationship, and within that, the right of the patient to have his or her wishes implemented at an end of life when they may not be capable of communicating that decision. Now, our bill does not allow this option to be exercised through an advance directive, through an agent, through a conservator. It can only be exercised with a terminally ill patient who is capable of engaging in conversation with two separate independent physicians 15 days apart, and if they suspect that there is any impairment of decision-making capacity, they are required to make a referral to a psychiatrist or psychologist for further profiling of that patient's mental capacity. Ultimately, colleagues, we're talking about a very small universe of Californians. It has been a very small universe of Oregonians. But that small universe includes families of family members, loved ones, who have a terminal diagnosis and who do not seek to end their life. For whatever reason, they've been dealt a death sentence. Not because they chose it, not because they seek to end their life in what is considered the irrational act of suicide. And if you read psychology and psychiatric journals, suicide, I don't believe, is the appropriate description of the exercise of the right we seek to establish. Suicide is defined as an irrational act, an end-of-life choice within a spectrum of hospice care, palliative care, pain management, and choosing the terms by which we choose to transition is compassionate. It is not suicidal. We have with us today, at the back of the floor, families who have struggled with this. Families, one family that had to move to Oregon to respect the wishes of their daughter and wife. And what hasn't been shared today are the stories of those families in Oregon and other states where a family member suffering a terminal illness has been able, with their family, to pull that family together and choose a time, a place, and a compassionate transition, while there is still an ability to express love, to express appreciation, to express appreciation for life, and to say a dignified goodbye. The stories we haven't heard today of the bonding of family members who participate together in exercising this, yes, very, very irreversible end-of-life option, but one that leaves family members with memories of that loved one, engaged, cognizant, aware of their surroundings and their loved one, and able to say, I love you, and wish them a farewell, holding hands, with tears flowing, yes, but with an ability for those family members to carry on with a memory of that loved one, exercising their autonomy and choice as an individual, and yes, able to share their goodbyes and their love in a wholesome way. Compare that to the right in California today to get hospice care and to be anesthetized with morphine in ever greater doses, where you are unable to communicate with your loved one. You have family members holding vigil, often playing out struggles of unresolved decisions about advanced life care decisions, and unable to communicate with that loved one, but with physician-assisted or medical provider introduction of ever-increasing doses of fatal medication. That is the status quo in California today. And so in essence, we have laws in California that are being violated every day. So the question is, people have said, well, should the state legislate? Should we make laws that affect these end-of-life decisions? Members, we are living in a state that prohibits a patient and a doctor in that very special confidential relationship from deciding what's in the best interest of that patient. And we do not afford this as a choice available to a patient in that very private and confidential and trusting relationship with a healthcare provider. We, the state, say, no, we're not going to sanction that. You can go buy the gun, you can drive off the cliff, you can terrorize your family and leave them with that image of you versus one of joining together, holding hands, and expressing love. It's been suggested that the Hippocratic Oath and the ethical pledge of physicians is only to extend and sustain life. I would direct my colleagues to more recent ethical literature, peer-reviewed medical ethicists, end-of-life ethicists, who suggest that in addition to curing and healing, another part of that ethical pledge is to reduce pain and suffering. And if it is the will of a patient to have the option to reduce that suffering, is it for us to legislate they can't? In some ways, this is the ultimate libertarian issue. The respect of the sanctity of life and the autonomy of the individual. with a carefully crafted piece of legislation that builds in very strict safeguards that protect against the type of legitimate concerns of coercion or of some type of economic incentive, the requirement of 2 independent physicians, psychiatric evaluation, the ability to rescind. And what we've learned from the state of Oregon and other states is that there is a cohort of people who gain peace of mind by having access to the prescription who end up not having to use it because hospice care was effective, because palliative care was effective. But it provided a peace of mind that allowed them to face death with their family member and loved ones, knowing that if that pain isn't controlled, if the decompensation is too egregious, I have this option. Now let me address the concern of disposal and storage. It's a legitimate concern, it's an important one, and we've addressed it in the legislation. First of all, we draw on Oregon for a lot of what informs us in improving upon Oregon. There's not a single case in Oregon of an end-of-life prescription ending up in the wrong hands and used for the wrong reason. And to suggest that we should control this prescription differently than we control existing lethal prescriptions that are in people's medicine chests today, all through the state of California, a burglar, a child, every day in this state can access lethal pharmaceutical prescriptions. There's no evidence of this one being misused in Oregon. It's also, you should recognize, prescribed in tablets, multiple tablets that have to be removed, mixed together into a cocktail, including anti-nausea pharmaceuticals to prevent the expulsion of the end-of-life drug. But it requires several steps for it to become a lethal, life-ending cocktail, is what it's referred to. We believe there are strong protections. We have in the bill provisions for the disposal, consistent with California law, of a prescription that is not used. And again, we are fully committed to continuing to work on those. I want to close by, again, thanking our colleagues for this conversation, asking you to recognize that our status quo is not one that is void of families having to grapple with these end-of-life issues. We are joined today, as I mentioned, by the husband of Brittany Maynard, by her mother, by Dr. Olvera, whose daughter, Emily Rose, at the age of 25, died from cancer, from leukemia, begging her father physician to help her in that transition, and he was left only with the answer, "Mija, I can't legally do anything," and he had to watch this horrific deterioration for which no medication was able to ease the pain and the suffering that he and his family members had to endure. So these family members now today continue to work to carry the legacy of their lost loved ones, a commitment that in some ways extends the pain of their loss every day, but which also keeps alive the legacy of that loved one by hoping that other Californians in that limited universe of being determined by 2 independent physicians to have a terminal illness with less than 6 months to live, should we include in that range of existing options of hospice care, palliative care, and pain management, an option under these very strict conditions to respect that terminally ill patient who wants to live, who prays for the cure, and yet who fears decompensation that can include seizures, loss of ability to communicate, loss of control of bodily functions, and a decompensation totally unnecessary in a modern world where we have access to caring, loving palliative care, hospice care, and medical care that, again, recognizes the primacy of the doctor-patient relationship. I do want to close by just also acknowledging the engagement with so many stakeholders, from the disability rights community, from religious organizations, the California Medical Association, the California Hospital Association, nurses, other healthcare providers. And the engagements have been sincere, they've been genuine, we've had an open door, and we've invited inputs that we've considered, and when we've included those inputs, it's been with the understanding that it would not necessarily remove opposition, and it hasn't from some sectors. But nonetheless, we've taken into consideration and included in this legislation the protections important to those groups. And colleagues, here's our choice. We navigate this through the legislature to create a compassionate law in the state of California, or we fail here, and we know this will go to a ballot initiative where Californians, who in overwhelming majority in polls support establishing this right in California, will have the choice of voting yes or no on a ballot measure that will not be subject to reform, to review, or to change other than through another ballot measure. I suggest that it's our responsibility, it's our constitutional responsibility to navigate the shores of a changing world, a world that sees this option, indeed what it's called, a compassionate option. Compassion with choice, death with dignity. Those happen to be the names of two organizations that have worked on this, both here in California and nationally. And what pulls and adheres the fabric of people who advocate for this? Almost without exception, a story of a lost loved one, a close family member, or somebody faced today with the crisis and the reality of a terminal diagnosis. Members, this can be done in a manner that is not abused and that it respects the love and the compassion only of those who voluntarily seek to exercise it. So with that, my friends, I thank you. Again, I thank my joint author. I want to thank the pro tem, who has also helped us to have access to colleagues and members. And I respectfully urge your aye vote, your historic aye vote, and your recognition of a changing world where we have choices and options that are ethical, compassionate, and let's make them legal. Thank you.